All right, we're going to go ahead and get started. Good evening, everyone. My name is Aisha Beard, and I'm a prevention specialist here at the Agency for Substance Abuse Prevention. We are dedicated to strengthening awareness through prevention education, awareness programs such as this one, and trainings. And on behalf of the ASAP Board and Executive Director, we would like to thank our Opioid Roundtable Committee members such as Ross, Hope United, JSU CRC, Bradford Health Services, Alabama Department of Mental Health, Self-Recovery Detox, and the U.S. Attorney Office of the Northern District of Alabama, who have contributed to making this event a success over the years. This committee works extremely hard within their professions to help make our community better informed of the resources available. The agency would also like to thank Bradford Health Services for allowing us to use their webinar platform, as well as providing the CE hours for this program. The purpose behind this roundtable is to raise awareness on the dangers of prescription misuse, as well as to make sure the community is alert of the resources available to them. So, real quick, as we still have people attending, I have an icebreaker. How many fentanyl-laced pills in the U.S. did the DEA seize in 2023? And you can use the chat box below to send in your answers. I see someone said billions, 25 million, 91,000, okay. 15 million, 42 million. And someone was very honest and even said, I have no idea. So the correct answer is in 2023, they seized more than 78.4 million fentanyl-laced fake pills and nearly 12,000 pounds of fentanyl powder. The 2023 seizures are equivalent to more than 388.8 million lethal doses of fentanyl. So, did you know that the DEA revealed that 7 out of 10 fentanyl-laced pills now contain a potential lethal dose of fentanyl? So, according to the Alabama Department of Public Health, 835 Alabama residents, and that's more than 2 deaths per day, by the way, who died from overdose in 2022. In Calhoun County alone, we had a total of 55 overdose deaths in 2023. And next door to us in Talladega County, we had 11. So when I look at these numbers, I see someone's brother. I see someone's sister, their mother, their father. The numbers continue to climb, and we know through our electronic death registry system that fentanyl has something to do with that. Synthetic opioids, including fentanyl, are now the most common drugs involved in drug overdose deaths in the United States. I wanted to share that fact with you all because this is hitting our community aggressively, which is why as a community, we need to come together to help raise awareness. So before we get started with our program, I want to share some important information with you. You are viewing this webinar format, which means that you can see the presenters, but your video and audio are off. Please use either the chat or Q&A functions located on the bottom of your screen to ask questions regarding anything discussed or specific questions for the presenters. Please state which panelist the question is directed to. Again, please state which panelist the question is directed to. At the end of the presentation, we will have a discussion where questions received will be answered at that time. Today's session is eligible for 2.0 continuing education contact hours. Bradford Health Services is providing the continuing education contact hours at no charge to you. Please note that you will receive a post-session email tomorrow that will include a link to a video recording of today's presentation, resources shared, and include a link to an evaluation. The survey link will be open for 30 days post-webinar. You must complete the CE evaluation in order to receive credit for your participation. Certificates will be sent via email to those who complete the evaluation within 2 weeks. After the survey link expires in 30 days, CE credit will no longer be available. There will be an additional survey as well provided by ASAP. Finally, if we experience any technical difficulties today, please stand by while we do our best to resolve them. If the webinar gets interrupted in any way, we will get logged back in as quickly as possible. So now at this time, I would like to introduce our speakers of the evening. We have Kendra Holmesley with Bradford Health Services, Eugene Jacobs with ASAP's FBSS program, U.S. Attorney of the Northern District, Prim Escalona, Amanda Bullard with Bradford Health Services, Ashley West with Silver Linings Recovery, and our keynote speaker, Cheney Gordon, who is with ASAP as well. So at this time, I would gladly turn it over to Mrs. Prim Escalona.
Thank you so much. I think this is working. So someone raise your hand in the chat if it's not. It is so good to be with y'all for another year. This is an event that I have been a part of in the past, I think, 2 to 3 years, and I just enjoy it so much because I learned so much, and I know that y'all will as well. And I love watching those numbers tick up on the participants because it means that there are so many people across our state who are committed to addressing the substance abuse problems that our state is plagued with, and have decided that they will spend their Tuesday night learning more about what they can do. And that is so reassuring. For 2023, overdose deaths for our nation and in our communities across Alabama continued to surpass all previous annual totals. So last year, more than 112,000 Americans died due to a drug overdose. That loss of life is staggering, and it causes irreparable harm to families in every facet of our society. Someone in our country dies from a drug overdose every 4.5 minutes. So we've been on this webinar for 7 minutes, which means that we're already had one death and are quickly approaching a second one. 22 teenagers die each week. That's essentially an entire high school class dying of a drug overdose every single week in our country. Opioid-involved overdoses are the leading cause of death for people 18 to 45 years old in the United States. And we in Alabama are not immune from these sad statistics. More than 1,500 people die each year in Alabama due to a drug overdose, and that number only continues to rise. Were it not for the more than 5,000 units of naloxone used to reverse overdoses in Alabama last year, this death toll would be far, far, far higher. Our current efforts to save lives and heal families from addiction, quite frankly, are just not enough, and more is needed. There is no margin for error in this fight against fentanyl and other opioids that are responsible for this unprecedented loss. Federal and local law enforcement are throwing every resource we have at stemming the tide of drugs and deaths in our communities. In recent years, federal prosecutors in my office have prosecuted prison guards that have smuggled drugs into prison. Law enforcement has broken up pill mills and placed doctors in federal prison, and we've stopped numerous out-of-state traffickers from bringing drugs into Alabama. Law enforcement and prosecutors will continue to do our part, but a strategy that relies solely on law enforcement, prosecution, and incarceration to end the drug epidemic in the United States will not accomplish that goal that we all so much desire. Education and prevention must be our lead weapon in our fight against fentanyl and opioids. Enforcement actions and prosecutions can only take place after drugs are in our communities, and often after trauma has already occurred. Education and prevention are the tools that will meaningfully reduce the demand of illicit opioids from entering communities. Additionally, naloxone is the best tool that we now have available to reduce the harm of opioids and to give people one more chance to receive help that will save their lives. Naloxone is now available over the counter in Alabama, and communities must make efforts to have naloxone readily available in ample amounts. Often, it now takes first responders 2 to 5 doses of naloxone to reverse fentanyl overdoses. Our shared response today to the rising drug-related death rate in our communities must be unlike our previous approaches. The work of ASAP and other partners to prevent and break the crippling cycle of drug dependency is essential to reduce the loss of life that our communities are suffering. The road to recovery from addiction is rarely ever a straight, unbroken path. Our community and our institutions must be persistent in our compassion and redundant in the safeguards that we place around those struggling with addiction. The Department of Justice, the Alabama Department of Mental Health, and other agencies are pouring out help in Alabama in terms of millions of dollars for life-saving naloxone, training for law enforcement to provide a pathway to treatment instead of jail, and to support the children of parents who are struggling with addiction. I fiercely applaud your work, and I stand committed beside you. Please never hesitate to let me know how our office can lend its support to enhance your efforts to save lives and spread hope in our community. Thank you so much.
Thank you so much, Mrs. Prim Escalona. Just to point out some of the things you was mentioning, 2023, you said 112,000 of Americans lost their lives to substance misuse, and that's every 4.5 minutes, you guys, she said. So these are just things to think about, and I'm just trying to picture that for the world, as well as with Calhoun County. We had 55 here, as I stated earlier. If you do the math, it's 52 weeks in a year, which means we had someone to die at least once per week. So these numbers are, again, we already mentioned, they're not just numbers. These are people's loved ones. So I really appreciate that information. And if you have any questions at this time, please go ahead and put them in the comments for her with her name. That way, at the end of this, we're able to answer those questions. Okay. All right, we're gonna move right along into our next speaker, Miss Kendra Humsley.
Hello, everyone. I'm happy to be here. My name is Kendra Humsley, and I work for Bradford Health Services as a territory manager. And I'm also a person in long-term recovery. So this roundtable has some special meaning to me, both personally and professionally. I've kind of got a little presentation to share with you. Let's see. Here we go. Well, it's hiding my. Okay, now. So as I said, I work for Bradford Health Services as a territory manager, and I am a person in long-term recovery. I got sober on September the 9th, 2009. I started working at Bradford in 2021, but I have been working in the substance abuse field since 2011. And I tell you all this because if you are someone who works in this field or encounters people who may be seeking treatment or seeking to get into recovery, it's important to know that those people may not look like I look today, but they could. When I got sober, I did not have a master's degree in social work. I was not a drug and alcohol counselor. And I wasn't really much of anything, but through recovery and working the program of recovery that I worked, and taking this one day at a time, I started setting some goals. And it seems that in recovery, if I set a goal, I can accomplish it. And so I just want people to keep that in mind when they're working with someone who is in active addiction. I personally am in recovery from opioid use disorder myself. And so I take it really seriously. You know what I do? I do this for a living because I'm a person in recovery. That was what was my motivation. I went back to school to get degrees and whatnot so that I could continue to work in this field and so that I could better serve those people that are still suffering with substance use disorders. And my own story and what I have accomplished, I know can be an inspiration to those that are still actively using, who think that they can never get the things back that they lost, or that they can never go to school and get degrees or become who they dream that they could be because of their substance use disorder. It's definitely possible. And I'm not the only person like me that I know. Most people I know in long-term recovery are very similar. And we go on to be really amazing people. I am a mom. I have 3 boys. They're here in this picture. They are 19, 15, and when my youngest will be 13 this year, which is crazy to me. And my oldest is at Fort Leonard Wood and will graduate AIT this Friday. And so I get to drive up there to see him. And yesterday, my husband and I celebrated 20 years of marriage. So I get kind of like a little emotional when I think about where I was and how far I've come. And I've been sober a little bit less than 15 years. So, you know, our marriage didn't start out so smoothly, but through, you know, it's grace and mercy. So, but I do want to talk to you guys about some treatment options. So we do recover. I'm evidence of that. And I work for a facility that provides substance abuse treatment. So I work for Bradford at Warrior. Warrior is one of Bradford's inpatient locations that is located just north of Birmingham. And I'm not sure why this is moving on its own. So. But at Bradford, we do have multiple inpatient locations, including a second location in Madison, which is near Huntsville. And we also have now 2 inpatient facilities in, I'm gonna have to figure out why it's doing that. I'm sorry. We have 2 facilities now in Mississippi. And we also have another inpatient facility in Tennessee, and it's still doing it. It's so strange. So here are some of the points of contact. This is a good time to take a screenshot of this presentation, depending on where you live. This is, these are my coworkers and who can work for you as your point of contact should you encounter anyone that needs substance abuse treatment. We have territory managers now in Georgia and Tennessee as well, if you are in those states, and there are 4 of us here in Alabama. But my contact information was on the very first screen as well. Let me go back to that. And you can screenshot that. My email is kholmesley@bradfordhealth.com, and this is my cell phone number. Now, maybe I won't have to keep messing with this, but I really don't know why it's doing that. Actually, I think I might. There we go. Sorry, it never fails that we have, you know, some sort of technical issue, I guess it gets to be me tonight. So at Bradford, we offer, I mentioned our inpatient facilities, but we offer multiple levels of care, like our inpatient facilities, and we also do outpatient and long-term residential. And so when you call into Bradford, or someone seeking treatment calls into Bradford, we are going to do a brief consultation with that potential client and make a recommendation for what level of care they might need. It may be with us, it may be with another facility, depending on, you know, what services they're seeking and their payer sources. But we want to help people find the right path to recovery. And as we go through the slideshow, there are some pictures of Warrior. This is Warrior at Madison. This is where our patients would first arrive when coming onto campus. And like I said, this is an inpatient facility, and we do intensive treatment and provide a safe and supportive environment for our clients. We also do a lot of recreational therapy at Bradford at Warrior. As you can see, as we go through these pictures, it is a beautiful campus. We are located out in the woods, and we take advantage of that. We do have some amazing recreational therapists that do a lot of group activities outside. They like to, build a fire and sit around that. And when they do group or do some sort of therapeutic activity on the ropes course or other activities that we have available. Another view of our main building as you enter campus. So every client that comes in is going to start at detox. And that is because not everyone necessarily is going to need detox, but we want to at least get our eyes on them and make sure that they're medically stable. But most people who are entering substance abuse treatment do need detox, and we are able to do that. We have medical staff, and one of those people is here today that you'll hear more about detox and medication protocols from her. So I'm not going to go over that stuff. But they come in and we can treat their physical withdrawal symptoms for whatever substance that they're coming off of. And then they can, once they are stabilized and feeling better, they can move on into some of our treatment programs, into our primary programming or our extended care programming. So our extended care program is a program that is located, we call it Limestone Ridge. When you come onto campus, there's kind of two campuses. There's Limestone Ridge right when you enter at the top of the hill, and you go down. And the previous picture that I showed you at our main lodge where our detox center is located and our primary cottages are down the hill. So our extended care program is 6 to 12 weeks. And it is a great program for people who have had a hard time establishing or maintaining long-term recovery. Maybe this is somebody who's had multiple treatment attempts, multiple relapses, or maybe they haven't come to treatment a whole bunch of times, but they are someone who's had a lot of trauma in their life. We're able to address things in a 6 to 12 week program that we can't always address in 20, 30 days, like in our primary program. We have some amazing therapists that do a lot of great work. And we have groups that meet about grief and trauma and those kind of topics. So highly recommend this program if you have someone that maybe fits some of that criteria. Here's an aerial view of our campus. So you can see, well, you might not can tell, but you can see some of our rope courses from this picture in the top right and top left. We also offer PHP, which is a step down from inpatient, where our clients can reside at home and come, or supportive living, sober living, and come to the facility for intensive counseling and treatment. This is that was one of the pictures from our up on Limestone Ridge, one of those cottages. This is where sometimes they will sit and do groups. And we do have some specialty programs, including a program for healthcare professionals, young adults, legal and business professionals, and our Heroes Path veterans program. So at Warrior, if you work with the veteran population, they have the opportunity to do our extended care program, which is an amazing opportunity. They do not have to have insurance if they have benefits through the VA, which is amazing. And they will get at minimum 6 to 12 weeks of treatment. And again, it is in extended care, but we have a separate program just for veterans. So they will be with their peers. But we are going to address those issues related to trauma and things that are very common with your veteran population. This is our wellness center on campus. Our clients really enjoy this because we have our gym, which, as you can see, it's really amazing. Physical fitness and activity can not just be a therapeutic aspect to people's recovery, but a lot of clients and people in recovery exercise and activity is an important part of their recovery for them. So we want to support that for people who that is important to them. Of course, this isn't a mandatory part of the program, but most people do enjoy it. We also do offer yoga there. This is the main lobby. This is where our families would come in. If you bring someone to Warrior, the family can sit here with them as we work through the admissions process. So in the colder weather, we'll light the fireplace, and we just want to really create a comfortable environment. And some more of our outdoor areas. You can see this area from the cafeteria. This is one of our cottages at the primary program. So in our primary program too, we have we separate men and women. And so we have a program for young men, and then our women would be in a different cottage. But we're able to separate men by both age and gender. This is another view of one of our cottages. And that is all I have for y'all today. Again, here's my contact information. Should you ever have any questions about Bradford Health Services, or even if it's not Bradford related, if you have someone you know or love that is suffering from substance use disorder or opioid use disorder, and you just want to give them a person's number that can help them, you're welcome to give them my number. I'm happy to talk to anyone. Thank you.
Thank you. Thank you so much, Ms. Kendra. And just to piggyback off what she was saying, you guys, about the resources, I want to talk about our very first opioid roundtable we had. We had a young man that stood up asking about resources for his daughter, and they was all in the back. So this is why we do this, you all, just to make sure you are aware of all the local resources that are out there for you, and to make sure you are able to get that information. So I'm hoping a lot of you was able to take a picture of that contact screen. That way you are able to call and get more information as needed, okay? It's very, very important. All right, thank you again. And I would like for us to go to our next speaker, Miss Amanda Bullard.
Everyone, I'm going to share my screen with you. Okay. Can everybody see everything okay?
Yes.
Okay, good deal. All right, so we're going to get going. I'll introduce myself just a little bit first. My name is Amanda. I am a doctor of nursing practice, a certified addictions registered nurse, and a fellow of the International Academy of Addictions Nursing. A lot of times people don't know what all those letters are, so I just wanted to kind of explain that a little bit before we get going. I've been at Bradford since 2009, so I've been working there for 15 years and serving in this role for 13 years. In that time, I've got to take care of a lot of people from all walks of life. I know Kendra had mentioned, they don't always, everybody doesn't always look the same when they're in active addiction. And I can definitely speak to that. We get to see a vast change from when they come in to when they leave us. So we're going to talk a little bit about that today. I don't have any disclosures. It was requested that we cover alcohol use disorder with the medication assisted treatment associated with that for just a little bit. So we will go over that a little bit as well. Everybody's already shared a bunch of statistics, so I'm not going to spend too much time on this. But I just wanted to kind of give you a little bit, just add a little bit to what everybody's already kind of shared. So pretty much 50% of the population is going to be affected by addiction in some way, whether that means it's personally for them or through a family member, a friend, or whether they have a comorbidity from a prior substance use problem. So it's going to affect 50% of people. If you are a child of an alcoholic or someone who already has an addiction issue, then you are 4 times more likely to develop a substance use disorder than children of non-alcoholic parents. There is some genetic predisposition to that. And then, like I said, there's a few other statistics that we don't really have to talk too much about. But I did want to relay, because we're going to talk about overdoses. So 70% of all even benzodiazepine related overdose deaths include opioids, primarily fentanyl, which we've already talked about. So not only are we going to see that opiates themselves are a problem, but they are combined with other substances which really amp things up for the overdose risk. So this is really just some statistics about overdose deaths. And you can kind of see here the synthetic, this gray line here is synthetic opioids, which is primarily fentanyl. So you can see how much that is spiking up. This one includes such things as like benzodiazepines that include opioids. And you can see, so benzodiazepines primarily with opioids is at much higher than benzodiazepines alone. So people will use these in combination, and it makes it much more likely to overdose from there. So we're going to talk a little bit about what constitutes a use disorder, and really just so you kind of have an idea of what we're looking at when patients come in for admission, how we determine whether or not they have a use disorder that warrants treatment. So one of the things is that we go through our DSM-5 criteria checklist, and we look to see if any of these things apply. Basically, are they taking the substance in larger amounts over longer periods of time? Do they have a constant desire, or have they attempted to stop before but have been unable to, or they can't control it? So sometimes they'll say, I've been able to control it up until this point. So if they kind of voice that, they spend a great deal of time obtaining, using, or recovering. So one of the things that you'll hear patients say is that their whole day is just spent obtaining their substance, whether it's whichever substance it is. And then they'll have that craving and strong desire and urge. They'll even use when they should be fulfilling major roles. So whether at work, home, or school, they're using instead of taking care of their family. They're using instead of going to work. They're using instead of doing their schoolwork. And then they continue to use despite having consequences. So my husband's leaving me, but I'm going to continue to use. I've lost custody of my children, but I continue to use my substance. And then they continue to use in physically hazardous situations, so drinking and driving and that kind of thing. So basically, there's all these different criteria. We determine which one the patient applies to the patient. And if they have 2 to 3 of those symptoms that's listed on the DSM-5, then they're considered to have a mild substance use disorder. If they have 4 to 5, it's moderate, and 6 or more is severe. And so let's run back to this right quick so you can kind of see, if you have a patient who started taking pain medicine because they had a surgery, and the goal was to have them off that pain medication in 2 weeks, but they are taking it, for several months because they just can't, their pain is just persistent, then that would meet several criteria here. They're taking it longer, over a longer period of time. They have to take more to get the same effect because they've been taking it so long now they're building up tolerance. They could report that they have to go and see the doctor a lot to get more prescriptions. So they're spending time obtaining it, or they're craving it. So you could easily hit several of these things and not really even know that you're even at risk for having a substance use disorder. A lot of our patients will say that I was just taking what's prescribed to me, and they don't understand the ramifications of, when someone has a substance use disorder, what that kind of looks like. And so it doesn't always look like someone being homeless or buying off the street. It looks a little different for everybody. So this again is just a little bit more of the checklist that we look for to determine whether or not they're mild, moderate, severe. And so once we determine if they have a substance use disorder and what level it's at, then we can start looking at how are we going to combat this? How are we going to treat it? So medication-assisted treatment specifically is a harm reduction model that's used to essentially prevent relapse. That's more of what's focused on relapse prevention. And how you determine, if someone's appropriate for that is if their risk of relapse versus the benefits of harm reduction, like which one, are they at higher risk of relapse on their substance? Or would they be better off to go ahead and take a medication-assisted treatment to assist them to achieve recovery? Because what we see a lot of times are people that will say, well, I don't want to replace one med with another. I don't want to replace my substance with a medicine. But the studies show that they are able to live a more functional and productive life if they have a little bit of assistance from medication. It's individualized, meaning there's no time that someone should plan to be off of it. So nobody, is ordered medication treatment, assisted treatment, and then said, okay, but in 3 months, you won't be taking this anymore. It's very individualized. If the patient is motivated and continues their recovery program, they could potentially determine with their treatment team that they want to come off of it at a certain time. That's something that they'll work on together and be part of the treatment team and part of their plan for their medication assisted treatment. But there's no specific time frame. What we do know is if you can keep a patient engaged in treatment for 12 months, then they have a much higher likelihood of achieving a long-term sobriety, some form of long-term sobriety, whether it's with medication-assisted treatment or it's just working their program with abstinence. If you can keep them engaged in treatment for 12 months, they have a much higher liability of obtaining that longer-term sobriety. So for most people, what we found with medication-assisted treatment is that it quiets the brain. So the cravings, the obsessive thoughts, the need to obtain it, MAT will kind of help to allow the individual to focus on treatment and recovery instead of the constant obsessive cravings and thoughts. It allows them to live a productive and functional lifestyle free from illicit substance use, and it improves clinical outcomes for individuals with serious mental illness. You will see a lot of our patients are dual diagnosis, so they have a psych issue in addition to their substance use. And for those that are on MAT, they're able to really have improved clinical outcomes associated with that. So the model kind of looks like this. MAT is essentially therapy combined with medications. For opiate use disorder, there's 3 approved medications for MAT, and that's what you see on the right side of the screen here. The methadone, Suboxone, and Vivitrol are the 3 approved for opiate use disorder. So alcohol, and we're going to cover alcohol a little bit, and then we'll talk more about MAT specifically. So one of the things the reason that I put this on here, these numbers are the BAL or breathalyzer blood alcohol level that we would see in individuals who necessarily do not have a drinking problem. So someone who comes like a person who drinks randomly on occasion once every few months. If they were to have 1 to 2 drinks, they would have maybe like a 0.05 BAL. In our state in Alabama, 0.08 is the legal limit. And then if they had 5 to 6 drinks, of course, depending on size and metabolism, but they might be a 0.10. And they would experience these things: difficulty driving, coordination, impaired judgment. And then as the drink numbers go up, their BAL goes up. And so what I can tell you, working at Bradford for 15 years, prior to COVID, it was rare to see someone come in with a BAL above like anywhere between 0.3 and 0.4. Since COVID, we have seen a drastic increase in BALs. Our machine reads up to 0.5, and we've had several occasions where it just reads high, and we have to send them out to the hospital because it's too high for us to assess at our site. And, we need to make sure that they're not going to, because they're talking to us at a 0.5, where this says most people would have respiratory failure and death, but their tolerance is so high that they're used to functioning at such a high level. So as you can see, the more drinks that you're drinking, the higher your BAL goes. As you develop tolerance, that you're going to drink more and more and more to try to obtain the same feeling that you got from the previous amount. So this kind of just shows you a little bit of where some of our patients are. They're functioning, not very well, but they're able to function at these higher levels, which tells you how high their tolerance is. Now, additionally, the whole reason for all of this, kind of going over all this, is to show how patients will just continue to progress unless we do something to stop it. And so that is what the goal of MAT is. It is metabolized in the liver, and there's some very long-term complications from alcohol use. It can be very serious. You can have cerebellar degeneration that does not change. So it could potentially be chronic, meaning it never gets any better. There's neuro complications and just several significant health issues that could happen for people who continue to drink alcohol. So for detox from alcohol, that's a medically supervised withdrawal. Basically, it means they've taken their last drink and we're basically starting the clock from there. The severity really depends on how long they've been drinking and what type of alcohol they've been consuming. Chronic drinkers will usually they'll start having symptoms within 12 hours of their last drink. And honestly, for our patients that have those higher BALs, they could start having withdrawal symptoms when their BAL is a 0.3. It doesn't take very long when they're used to having so much board. So if we're unable to control the withdrawal, then you could potentially develop delirium tremens. That's the most severe and really requires hospitalization. So when we see patients that, like I said, are kind of outside our scope, we'll go ahead and send them to the hospital and let them take care of that. So uncomplicated withdrawal generally is complete within 2 to 4 days of their last drink, meaning if they come in and we can stabilize them within 2 to 4 days, they're kind of over the hump, essentially. They're still going to have some withdrawal symptoms and cravings, but we'll address that in treatment. We assess them by the CWA scale, which basically includes some symptoms, and based on how their symptoms are going, we'll give them a score, and that tells us how we can medicate them. We primarily use phenobarbital and Depakote at our location for treating alcohol use disorder. We also have Librium for patients who are allergic to phenobarbital or on certain medications that don't mix well with phenobarbital. But that's probably about less than 1% of our patient population. So our primary treatment is phenobarbital, and they're on it for about a week. The good thing about phenobarbital is that it has a very long half-life. So a week's worth of medication will give us at least about 2 weeks of coverage for them, and kind of just helps them to stay in treatment with less withdrawal symptoms. If they're in the hospital, they're likely going to be giving them benzodiazepines for withdrawal because that's the recommendation for acute care. And then there's some other meds down here that we can give them as the provider deems necessary. So the medication-assisted treatment for AUD, we have 3 options for that. One of them is antabuse, and essentially it causes extreme nausea and vomiting if you ingest alcohol. What we have found also is that it can do this if you touch things with alcohol in it. So patients have to be aware that they need to have alcohol-free hygiene products. If they're checking their blood sugar, they have to kind of be aware of that. We have had one patient to use the alcohol prep before checking their blood sugar and get very sick from that while they were on antabuse. And so if antabuse is not appropriate for that patient, then we also have Campril, which basically is thought to just restore chemical balance in the brain once they stop drinking. It doesn't help while they're still drinking, but when they stop drinking, then it helps. And then naltrexone, which is the oral form, or we have the extended release injection of Vivitrol. This is the medication that it specifically helps to quiet the brain and reduce cravings. So that if the extended release injection is given once every 28 days, and we do provide that at our IOP locations. So that our patients, as they're coming to IOP, they're staying engaged in treatment, and we're also giving them the medication. Again, these are when our patients discuss their forms of MAT with the provider, they go over all of these things. What is it? How is it given? How does it work? The goal really is just to keep them engaged in treatment and recovery in some way, really by any means necessary. So whichever one they feel like would work best for them, that's what we want to do. We want to meet them where they are and keep them engaged in their recovery program, whichever recovery program they choose. So opioids, we're going to talk about that a little bit and go over its MAT. So it's any substance that binds to the opioid receptor. And that's important to remember because I'm going to talk about some substances that you might not consider opioids. And so it's derived from poppies, primarily used to treat pain. Things that you've heard of before: heroin, morphine, codeine, these are all examples. It causes CNS depression and basically primarily also causes respiratory depression. So they may not remember to breathe because it's so slowed down. And then it has really strong reinforcing properties that can trigger addiction fairly quickly. So tolerance and dependence develops very rapidly, and it requires 100% increase in the dose to achieve the desired effect. So if you were drinking alcohol, you might could have a little bit more to drink. But if you're taking, and have an increase in the desired effect. But for most opioids, you basically have to double your dose. And if you're doubling your dose fairly frequently, then you're going to have a really high risk of overdose. So these are some of the things I mentioned that you might not consider opioids, but remember, an opioid is anything that sits on the receptor. And so essentially this is like our gas station drugs, Tianeptine, Tiana, and Zaza. Those are classified as tricyclic antidepressants, but they act as opioids, and we will treat them as opioids. They target the same, they have the same targets in the brain as natural opioids and produce the same effect, but are often much stronger than other natural opioids. So withdrawal assessment specifically for like these gas station drugs is equivalent, and the treatment of that is equivalent for natural opioids. We have tried several, different methods of treating these substances, and ultimately MAT is what has proven to have the best outcomes for these patients. So illicit opioids, there's no specific purpose for them. They're really just abused substances. And you don't always know what's in them. And what we're finding with this too, it's not just with opioids, but in other substances, cocaine, meth, things that they're buying off the street, they're being laced with fentanyl. And patients don't even know that they're taking it until they come into treatment and they don't understand why they're testing positive. So one of the most detrimental effects from addiction and of opioids is the loss of frontal volume in their ventricular spaces. So that your frontal lobe kind of helps with self-control and self-regulation. And because they're using this, they have no self-control. They're literally gone back to like primal needs, and their only need is to obtain and use the substance. That becomes their primary focus in life. And there's not, because of that loss of frontal volume, there's nothing they can do to control that. So that's where treatment and utilizing MAT is really their best option. So for opioid withdrawal, it essentially kind of looks a little bit like flu withdrawal or like flu symptoms, really. They'll have abdominal cramps and muscle and joint pain, vomiting, chills, diarrhea. So we assess this through the COWS assessment, the clinical opiate withdrawal scale. And based on that, it lets us know when it's time to start medicating them. The onset of withdrawal really depends on the type of opiate that they used and for how long they used it. And we have a symptom-based approach so that we know when to start their buprenorphine. For patients that don't want to be on like buprenorphine MAT, then we can do a taper of buprenorphine, which helps to address their withdrawal symptoms and then allows them to be placed on, say, naltrexone or Vivitrol MAT. Clonidine also is a blood pressure medicine, but it specifically helps with opioid withdrawal. Our patients have good outcomes from that. So OUD MAT is the gold standard of treatment. It's, again, a harm reduction model. Evidence shows that those who participate in it maintain treatment engagement longer and are 80% more likely to achieve long-term recovery. So MAT is really essentially a lot of people's best option to achieve long-term recovery, and it is the gold standard of treatment. The medications that we use for that are naltrexone or Vivitrol. You might remember I mentioned that for alcohol. It works for both. Naltrexone is the oral tablet and Vivitrol is the injection. Buprenorphine products such as Suboxone or Sublocade. Suboxone is the film strip and Sublocade is the 28-day injection. There's also a new option called Brixadi, which is another extended release injection, and it can be given weekly or monthly. And then methadone is essentially the oldest and most studied and most tried and true form of medication for opiate use disorder. Just like for alcohol use disorder, we discuss all of these options with the patient and give them good patient education so they can make a choice that works best for them. Naltrexone essentially blocks the opiate receptor, so nothing can get on there. Buprenorphine partially blocks it and partially fills it, and then methadone completely fills it. It's a full opioid agonist, and that kind of looks something like this. So as you can see, methadone specifically fits completely in the receptor because it's a full agonist. Buprenorphine, it has a little bit less of an effect. It's still very, like I said, gold standard, but it doesn't fit exactly in the receptor like methadone does. It fills it and has, it's a partial agonist. Naltrexone blocks it where nothing can get in there. So same thing like with Narcan, when patients are given Narcan, that's what it's essentially the same as naltrexone. It blocks the receptor, and it can even push all these particles off the receptor so that the patient doesn't have that respiratory depression and other symptoms to go along with an overdose. So naltrexone works the same way. Let's see, and then we're just going over a little bit more education about full agonists versus partial and antagonists. So there's a lot of studies and a lot of science and evidence to support that patients who are on MAT for OUD will decrease their mortality rate, improve treatment retention, decrease criminal activity. There's so many good outcomes from being on MAT. Essentially, you have a decrease in all the negative consequences and an increase in positive consequences when patients are on MAT and able to continue their treatment and recovery program. So naltrexone helps maintain abstinence and increase time in treatment and prevent relapse. Again, relapse is our number one. We've already talked about how we have all these overdoses. We have all these other things going on. So how are we going to stop it? Once patients are already using, our goal is just to keep them in treatment and do whatever we can to prevent them from relapsing and potentially overdosing. Our medical director, our previous medical director, Dr. Wilkerson, he used to always tell us, and it's really stuck with me, you can't treat dead. So if we can't get these patients, if we can't keep them alive long enough to achieve some form of recovery, then we're doing them a disservice. And so this OUD, MAT specifically helps them to stay alive longer to potentially live out that normal and functional life. Same thing with buprenorphine. These are just some good outcomes. And there's a lot of data to support utilizing specifically methadone in the justice-involved population. And I think I'm not sure so much about what the jails are using now. I think maybe some of them have Suboxone, but specifically, methadone is good it has a lot of good outcomes related to the justice-involved population. So we've talked about our protocol, so I don't want to get too much into that. But in an emergency response, we did talk a little bit about, I think Aisha talked a little bit about the naltrexone and, the Narcan, getting the nasal Narcan out to everybody. When patients leave Bradford, they have a prescription. I know they don't need it, but maybe they can't afford to pay for it over the counter or whatever. They'll have a prescription so that the Narcan is waiting for them at the pharmacy when they get there. And MAT really helps to, kind of prevent the overdose when combined with a treatment program. And I've gone over my time by 2 minutes. I'm so sorry. But if you have a smartphone and you want to scan my code, that will add me to your phone and you'll have access to me. You can email me, call me if you have questions about anything or, need some assistance getting into treatment. I'll be glad to do that. All you got to do is use your camera function on your phone. And when you hold it up to the QR code, there'll be a little yellow box pop up. You click on that and it will add me to your phone. Okay, and I will turn it back over to Aisha.
All right. Thank you so much, Amanda. That was a lot of information, you guys, to
It
take
was.
in. It really was. But honestly, for the past 2 years, I have been listening and looking at the ORT feedback information. And I heard you all wanted more information on MAT, which is exactly what she gave you. I do hope you did get her contact information because I cannot remember everything she just went over myself. But I do want to point out a few things. She was talking about how 50% are affected in some way. And that's big, to think about that, you guys. And one thing I would like to put together about the fentanyl situation that's going on. Think about a cookie. When you're baking cookies, you're mixing it together. Then you have your chocolate chip cookie pieces you're putting in it. All right. So when you bake it and you pull them out the oven, do all of them have the same amount of chocolate chips in it? No. So that's what we're talking about with the DEA numbers and how some of these fentanyl pills how some of these pills are laced. Is at one point, our law enforcement even made an announcement on Facebook, on all the social media platforms about fentanyl being laced in marijuana and everything. So this is a serious matter, you guys, and I'm hoping you're really taking this into consideration. Okay? So we'll go to our next speaker, Mr. Eugene.
Good evening, everyone. My name is Eugene Jacobs, and I work for the Agency for Substance Abuse Prevention in Oxford, Alabama. And my position with them is the Faith-Based Support Specialist Ambassador. What we do, and the reason that we do it, is we connect with faith leaders all across our state. We've even connected with them nationwide, because most of the time when people come to any individual for help, it's going to be their faith leader. Most of the time, we are the first line of defense. We're on the front lines when people have a crisis, but especially when it comes to substance misuse and substance use disorder. And most of the times when they come to the average faith leader, many of us are ill-equipped to help them, especially in that particular critical window that they need that help. There are over 12,888 religious institutions in the state of Alabama. And if the majority of the faith leaders in those religious institutions are ill-equipped to help people when they're struggling, if they're ill-equipped to send them the certified resources in their area, that is disastrous. So I want to, for context, tell you about a dream that I had at the height of the pandemic that actually opened me up to ASAP and the FBSS program. So I had a dream that, let me also mention that I've been pastoring where I grew up for 10 years. So I had a dream that at the place where I pastor, I was standing in the pulpit and there were no pews in the building and people were just rushing and rushing in to the sanctuary, and front and center, I could recognize one individual, someone that I know and I love. And that particular individual was just standing there with a smile on their face. And I knew that everyone that was rushing in was coming in for help. But in the dream, the first thing that I could think about was, it's the pandemic. We need to put on masks. We need to spread out. And then I woke up. Feeling horrified, and I was upset with myself because I didn't think about people that were coming to me for help. I thought about people trying to be safe because of the pandemic. And so it horrified me so much that I wanted to go back into the dream. I actually tried to go back to sleep and fix it, but my brain woke up by then and realized that this is just a dream. But the reason why I tell you that is because it gave me chills. It made me think about how I am as a faith leader in real life. Am I able to help people when they come to me? Am I trying to give them what I think they need, or am I actually equipped to help them in their time of need? Timing is critical when someone comes to a faith leader for help. Oftentimes, when we don't know exactly what to say at that particular point in time, people kind of lose trust in us because a lot of times the average citizen thinks that faith leaders are in the community, that we are boots on the ground. We know people, we know resources, and many times people have come to me about resources and whatnot. And I really now, since that dream, I'm determined to have the resources that I need to be able to help people. Little did I know that around the time ASAP developed the FBSS program, that particular individual I saw in the dream, their spouse came to me begging me to help them because that individual would not tell me that they were struggling with substances. The timing was perfect. It was almost like I was being prepared just to be involved with ASAP and FBSS. So I got an email to go to the first conference in Oxford in 2022. And when I went there to that particular conference, I realized how wrong I was as a faith leader and how ill-equipped I really was to help that individual. I learned that I had been participating in stigma. I learned that I did not know the difference between certified resources and other resources that were in our community that were mass as ministries that may not have necessarily been able to help them the way that some of the people like Bradford would help them. I learned that there was a lot of misinformation that I had that misled me. So I learned some things through ASAP concerning stigma, cultural competence, treatment planning. And as we went through the 2-day courses, my mind began to change. My heart began to change. And by the time I got done with that FBSS conference, I went back to our church. I set up a resource area where there was someone who needed help. Even if they didn't want to come to me, there at least were cards and there were phone numbers and posters that were there to help them out. The FBSS program at ASAP, we are set to equip faith leaders of all faiths. It's an interfaith program with a certified and resources to be able to help to direct people struggling with substances to those resources so that they can get the help that they need. It also equips faith leaders to tear down the walls of stigma so that we can actually hear the hurt, to hear those individuals and not judge them. I recognize that I was judging people, and I have to tell you that before I was introduced to ASAP's FBSS program, I just thought that substance use disorder or addiction was just a matter of choice. I thought it was a matter of making the right choice and everything would be all right. How wrong was I? And just to hear the language of people saying that they were in recovery, long-term recovery, even little sayings like that, that shocked me because I thought that once you stop using that you were done with it. That was it. It was over. No more talking about it. But to hear people talk about being in long-term recovery, so it completely changed my heart. So I just want to introduce you to a program that you may not know about, or you may have heard about it because we've had these conferences all across the state. We've had them in Mobile, Montgomery. We had a nationwide FBSS conference in Birmingham back in December. We're getting ready to have one in Dothan, April the 11th and 12th. We started in Oxford. We had one in Huntsville. And our goal is to get every faith leader in the state of Alabama armed with that information so that we can get in front of this endemic and hopefully put it to an end. At ASAP, we believe that prayer, prevention, treatment, and recovery do work together. It's not blasphemous to direct someone to a Bradford or to a Ross or to another certified center. It's not renouncing your faith to help. Yes, I am a faith leader. I believe in the power of prayer. I believe that prayer works, but I also believe that all of us are here for a reason. There are people who have their testimonies for a reason, their victories for a reason. And if we can work together, we can end this endemic, this opioid crisis, substance misuse disorder. So it's important to empower as many faith leaders as we can. I'm going to ask you, if you will, help us to recruit as many soldiers as you can. Doesn't have to be a pastor or imam or rabbi, whatever the case may be. If you are a leader in the church, please look us up at fbss.asaprev.com, fbss.asaprev.com. We put the information out on when we'll have our next FBSS conferences, or reach out to us at ASAP at any time because we need to spread the word. Thank you for your time.
All right. Thank you. Thank you so much, Mr. Eugene Jacobs. I do appreciate that information. And I seen some of the comments. A lot of people was happy to hear from a religious leader on this particular matter. So I do appreciate you for your time. And just to piggyback on a little bit that he was talking about, I will be announcing that information for anybody who would like to attend our upcoming FBSS training conference. And we also have, at this time, certified 270 religious leaders within the state of Alabama. Again, 270, and that's over the past 2 years. So we are very excited about this program and really looking forward to keeping it going. Okay, so we will keep it moving. And what I want to do real quick, I'm throwing in a little something before we move to our next speaker. We do want to talk about our Drugfish commercial. So at this time, I'm going to show you the commercial and hopefully you can hear it. Give me 1 second. Okay, and again, this is a commercial recreated based on DEA numbers from last year where there was stated it was 6 out of 10 compared to now 7 out of 10.
For 6 months now.
Yes, this is my soulmate. I'm so excited.
Well, we're about to go find out.
Why are we in the cemetery?
Well, seems like you've been drug fished. You're talking to fentanyl this whole time. I'm so sorry.
So I just want to pause it right here on this number, you guys, just so you can see what we was talking about. Where it's stating 6 out of 10 fake pills now contain a potentially lethal dose of fentanyl. That was just 2023, where we recently received these numbers in DC during our training. That is now 7 out of 10. And I'm hoping I was able to hear what was stated. If not, this was based off catfish and how, pretty much people are not who they say they are. So this was one based on fentanyl trying to set up a date, and which is why it was related to the graveyard, because if you're not careful, of course, an overdose can happen and it potentially could be fatal. So that was just the message we were trying to get across with that commercial. All right, so I will get to our first speaker. Well, not our first, but our fifth speaker, Miss Ashley West. You have the floor.
Hey everyone, my name is Ashley West. I am the Executive Director for Silver Lining Recovery for Women. I'm also a person in long-term recovery. My sobriety date is October 25th of 2017. Let me just start by telling y'all I'm extremely nervous. I was sitting here listening to all you guys talk and listening to all your statistics that you have, and it was Amanda that was talking about the DSM-5 for the use disorders, the substance use disorders, and as she's reading it off, all I'm thinking to myself is check, check, check. That's me. The sad part about it is, though, I didn't know any of that. Eugene, you were just talking before about how you thought you didn't realize you thought that alcoholism and addiction were a choice. And before I made it into the rooms of recovery, I felt the same way. I felt like it was a moral failing. I felt that I had, regardless of the way I was raised, I had made some really bad decisions because I was a bad person. And then I got in the rooms of recovery and I heard that we are not bad people trying to be good. We are just really sick people trying to be well. And I could feel that. And so what happened for me is I'm from Florence, Alabama. I came down to Anniston, Alabama in 2017 to get sober. And truly what ran me into the rooms were the courts. I was running from charges and things like that. I wasn't reaching for sobriety at the time. I wasn't reaching for a better life. I had actually burned my life to the ground so much that I didn't think there was any hope for me to have a better life. I just didn't want to go back to jail. And so I get down here to Anniston and I played around with recovery for a little while and I ended up getting a lot sicker. I've been on medication my entire life, either for maintenance or also for depression, on and off since I was 15 years old. I was told that I needed a pill to fix me for anxiety, bipolar, depression, different things. And I was always looking for the next pill that was going to make me better. And so for the first few months of my sobriety, that's what I tried to do. I tried taking everything to make me feel a little more normal. And I wasn't willing to put in any work and I wasn't willing to put in any action. I also believe in the power of prayer, like Eugene was talking about. And I work a 12-step program, but I also believe that faith without works is dead. And that if you don't understand what's wrong with you and we don't understand what the problem is, and therefore we might not can figure out what the solution is. And so what happened for me is I was put in a long-term recovery program. I was in a 12-month program, and we worked 12 steps. And I was surrounded with like-minded people who took the time to explain to me that this is a disease. And I didn't know that I have a disease that centers in my brain. And that once I put in that the choices I made were no longer my own. I abandoned my children. I lived on the streets. I was homeless for a long time, in and out of jails, in and out of rehabs, just thinking that that I had made some really bad decisions. And when I made it into the rooms of recovery and I made it around other women who took the time to go through the book and explain things to me, and I understand that I have a disease that centers in my mind, but I also have a solution, and that there's not a pill that I can take for me to get better. What I have is a spiritual sickness. So I got a sponsor. I started working the steps. I started attending meetings. I started learning about fellowship and service work, and working for the greater good and not just thinking about myself. What recovery did for me is it actually redefined words for me. I thought sober meant just not drinking and using. I thought sober meant that I could maybe drink sometimes as long as I didn't use. I learned that to be sober means to be of sound mind and body. And I got surrounded by women who taught me how to get there and how to learn to pray and to meditate and to work with other women. I heard a speaker say one time that their definition of commitment was staying true to what they said they would do long after the mood that they said it in has left. And that's what recovery did for me. Is my whole life has been centered around how I feel and what I want and what I think that I should do. And I learned early on in recovery that it doesn't matter how I feel. It matters what I do. Recovery is not for people who want it or for people who need it. It's actually for people who do it. And that's how I've had to center the last 7 years of my life. I went through a recovery house for about a year. I went on to a graduate program, and when I was around 2 years sober, I got to work for a detox as an assistant counselor. And what I learned during that time, I walked in not knowing if that's something that I wanted to do with my life. My grand sponsor had actually suggested it to me. I had started praying about what I wanted to do for a living. And I walked in my first day of detox, and I got to sit down with a group of newcomers and people new to recovery. And what I realized in that time is I absolutely love addicts. I absolutely love alcoholics. I love a newcomer. I love meeting a woman or meeting someone who has no hope left in their life, no hope in their eyes. They've lost their children, they've lost it all. And then all of a sudden you sit down and you look at them and you get to say, me too. I was just like you. I was an IV drug user. I did this, I did these things. I've been in jail. Because I like how Kendra and them were talking about how we don't look like we should have been in active addiction, or not everybody in addiction looks like they do now. And I can sit across the desk from a lady and I can look at her and I can tell her, I've been exactly where you're at. And let me show you how I dug out of this. Let me show you what I did to get better. Let me hold your hand through this. I worked for that detox for a couple of years, and then I got the opportunity to work for Silver Lining. We are a 12-step program. We require a 1-year commitment. What we do here is help women who are going through substance use, but also going through DHR, or we work closely with mental health court, drug court, that type thing, to get them connected to the resources they need to start building their lives in order to achieve the goals that they've set for them in the beginning. When Aisha first asked me to speak, I met her at a Ross event that I was speaking at, I think last year. And I didn't understand that she was asking me to be on the panel. I thought she was asking me to just come hang out with you guys. And all day I've been sitting here wondering what I have to offer. And I realized when I was sitting down and I was praying about this, that the greatest gift that I've got in recovery is the ability to take the worst parts of my life and everything that I was embarrassed about and everything I was ashamed of and everything I thought that I would never be able to use for anything. And I've been able to turn that pain into purpose. I've been able to teach other women not only how to get better and to get sober, but to become the women that God created them to be in the first place, and then to turn around and reach behind them and grab another girl to do that. I'm really honored that y'all asked me to be here tonight, and I've enjoyed learning from you guys, and thank you so much for letting me share.
Again, Ashley, thank you so much. Again, we did meet at a Ross event last year, and hearing her story did touch me for my own personal reasons with my father. So just listen to her and how she overcame, and just making sure you understand you don't never supposed to look like what you've been through. And she's a high definition of that. She has a powerful story that you wouldn't believe she um had all those obstacles she had to overcome. So Ashley, thank you so much. I'm looking at the comments. Everybody's, pleased and thank you for sharing. So I'm hearing people saying it's powerful. So again, great job. And I'm looking forward to many more things with you in the future as well. So at this time, I'm going to try to do this video one more time. I was told that we wasn't able to hear the sound, and I'm not that tech savvy, but we're gonna work with it. One second. Okay.
So y'all been talking for 6 months now?
Yes, this is my soulmate. I'm so excited.
Well, we're about to go find out.
Why are we at a cemetery?
Well, it seems like you've been drug fished. You've been talking to fentanyl this whole time. I'm so sorry.
All right. So hopefully you all was able to hear the video that time. And we're going to keep on moving forward. Oh, I hear someone say they heard it. So great. So again, thank you, Ashley. And at this time, I'm going to have Miss Chandy to slide on in the video. 1 second.
Good evening. My name is Chandy Gordon, and I am a prevention specialist at the Agency for Substance Abuse Prevention. And I am honored to be tonight's keynote speaker. So I'm excited to be here and be able to share my story with you all. As you hear my story, you're going to get a different viewpoint. You're going to get a standpoint from a child that made it out, and a child who was stuck, that didn't look like it was going to make it out. But I stand before you today not looking like what I went through as well. So you're going to hear throughout my story how much no one cared. So my story started at a really young age. I was about 8 when I started really realizing what was going on. I was 8 years old when I realized that my mom went from 2 or 3 beers to about 6 or 8 beers a day. And then 8 years old was the first time I ever saw my mother laying on the floor overdosed. And that was when her addiction went from just alcohol to alcohol and opioids. When I was 9, after I saw her overdosed on the floor, she got a divorce from my stepfather, and we did end up moving to Alabama. At this time, her addiction grew even worse to about 6 to 8 beers to about 10 to 12 beers a day. As her addiction grew worse, her neglect for me and my sister grew way worse. I was so neglected that I was made fun of at school because I didn't know how to properly take care of myself. As a 9-year-old, I should have been showed how to take care of myself, but I wasn't. So as I was going to school at 9 years old, I didn't smell good. I didn't look good. My hair wasn't groomed. My outfits were dirty. I didn't know how to properly dress myself, and I was made fun of very badly for several years. I had head loss so bad when I was 9 in the 3rd grade that my mother had to shave my head. And that was even worse at the time for a 9-year-old. I was bullied so bad at one point that I was cornered in the bathroom and beat up by some girls because of situations that I couldn't handle. all because my mother just didn't care. She cared more about her addiction than what was going on with me and my sister. So as time went on, I was 12 years old when my mother handed me her keys to her car the first time and said, "Here, drive to the store and go get my beer and my rolling papers for my marijuana." And because they knew her so well, they let me come and walk in the store at 12 years old and grab a 12 pack of beer and her rolling papers and walk back out to the car and drive away at 12 years old. No one asked any questions. No one cared. No one batted one eye at what I was doing. I was 13 years old when my mother handed me a shot of tequila and said, "Here, take this." And I told her no. And because I told her no, she hit me, told me I was an embarrassment to her. I was also 13 when she handed me marijuana for the first time. And I also told her no. She screamed at me so bad because she said I embarrassed her in front of the people that she was around. She said that I was an awful person and that I just didn't want to, that I thought her lifestyle was just awful and that I was jealous of her at 13 years old. Because my mother was so caught up in her addiction, I was sexually assaulted for the first time when I was 14 years old by people that she was putting me around. No one cared. No one absolutely cared. I was going to school, still not being properly showed how to take care of myself because my mother still just didn't care. I was 14 when I was at school, and my mother dragged me by the head of the hair out of band practice up the hill. And that was the first time that somebody called the cops. And later that night, cops showed up to my house with the woman who called, and they called DHR and they said that I could go with the family for a little bit until they figured it out. I stayed with them for 3 months, and that was the first time that anybody ever showed any love for me or care for me because there was no addiction in the home. Nobody was doing anything other than paying attention to me. I was showed how to take care of myself. I was given love. I was so happy for the first time in my life that when the DHR worker said that my mother apologized to her and said that she would no longer smoke in front of me or drink in front of me, she let me go back. The system failed me at the time. Nobody cared. So I went back with my mother, and the same thing kept happening. Sexually assaulted again. And all I did was cry. All I did was sit in my room and cry. People at church, I would go to church and they would coddle me because they didn't know what to say. They didn't know what to do. They didn't know how to help. All they knew was, let's just give her some love while she's here. And that was my escape. But as soon as I went back home, the same things happened. As I went out through, till I was about 18 years old, all the same things kept happening. And my sister, she didn't make it out of it. She ended up in addiction, pregnant at a very young age as well, twice. And then my brother, he didn't make it out either. He also, he's been recovered for about 2 years, and my sister has been recovered for about 10. But they both followed the same path as my mother. And for some reason, I didn't want to follow that path. So as bad as I wanted to give up and I wanted to take my own life, I did it. And it was just something that was holding me on. I don't know if it was the people at church that was giving me the love when they could, but I needed more at the time. I needed someone to step up and do something, and no one did. I needed more than just love at the time. When I was about 18 years old, I was a junior in high school, and I was going to my best friend's house for youth leadership. I was so proud that I was in something, no matter my awful circumstances. I was going with my best friend, and as she had pulled up, I had gotten back from church that day, and somebody from church gave me a bunch of clothes. And my mother saw the bags of clothes that I had, and she was so angry at me. She was so mad at me because she had already drank a 30-pack of beer and was working on her second 30-pack. And she was so mad because she said I was going around begging people and telling them that she was a bad mother and that I was just an awful daughter. And she was screaming and cussing at me. And my best friend is standing at the screen door hearing everything. And as my mother's throwing my belongings outside, I grab my duffel bag and my blankets and I go with my best friend to her house. And her dad looks in the car and he chuckles and he goes, "Looks like you're moving in." And I'm just crying. And so my best friend explained to her mom and dad what happened. Her mom goes, "Just give it a few days. When you get home from youth leadership Tuesday, I'll talk to her and we'll figure it out." You can tell that my best friend's parents had already discussed that they kind of didn't want to send me back, but they didn't know what to do. Tuesday, I walked in from youth leadership and my best friend's mother looked at me and says, "Your mother doesn't want you anymore." And that was one of the toughest things. And I wanted so badly to give up. But honestly, I think that's one of the best things that could have ever happened to me was out of the home of addiction. So I moved out. She didn't let me have any of my stuff. She burned everything that I had. So all I had was my duffel bag and my blankets that I took from her house and I started over new. And thanks to my best friend and her family, it was wonderful that they helped me. And without them, I probably wouldn't have been able to make it through. Excuse me, I knew I shouldn't have worn mascara tonight. I apologize. But there, from that point forward, I did end up going to college. I had some great people around me encouraging me going to college, and I did. Now, when I went to college, I did do a little more than I should have. I noticed myself drinking more than I should have, and that's the first time I ever tried to take my own life. When I realized I was becoming my mother, but I knew I wasn't. But it was just that doubt in my head that made me think that I was. So I knew I had to step away from alcohol. And throughout my time at college, I just knew I wanted to help people so bad. So I went to school to be a social worker. I'm proud to say that I did graduate from Jacksonville State University in 2019. And I did get my social work degree. And I knew when I got the call from ASAP in 2022 that this was the job for me. I didn't know how much an impact this job was going to make on me and how much I really related. And I'm so thankful that I'm here. But everything that I went through and that I saw has made this job so important because I relate so well. And my mother is still an alcoholic to this day. I have to be careful with how I treat my mother because she is still so caught up in her addiction that she still treats me like the child that she thought that the child that she raised. And I have my own son, and he is 4 years old. And every day is a constant battle to make sure that I am better than the mother that she was and that I don't fall into addiction. And it's very hard because you're so stressed, but I'm just so thankful for the opportunity to be able to help and save lives, with everything that we do here at ASAP. And that I was able to lead, even with my story, like this led me back to ASAP. So. But I have a call of action for you. Number one, pay attention to what's going on. Had someone really paid attention to that 12-year-old me that was in the gas station grabbing that beer, I could have gotten out sooner probably. I wouldn't be on the road at 12 years old. Be knowledgeable of the resources to help that individual. When I was going to church and being coddled and loved instead of helped and shown what could help me, I wasn't. And it was probably lack of resources. Number 3, follow up. After I left the family with DHR for 3 months, after they let me go back, nobody followed up with me. Everybody still loved me from a distance, but nobody followed up to see if anything had gotten better. Nobody checked in. Nobody, did a check in and on me at all. But for me, that's my call to action to you. Just be mindful, pay attention, and help where you can. And if you don't know where to help, ask for help for the children. Ask for help. Thank you.
Again, you all, I have heard this story from Chandy several times, and I still get the chills and tear up every time I hear her talk about it. And to think that was just a short version of her story. So again, I really do appreciate you for being able to stand up and share your story in front of hundreds of people. You're very brave, and I tell you this all the time. So again, that was very powerful. I'm looking at the comments, and a lot of people are saying that you're overcoming and that you're powerful and they're proud of you for not giving up. So great job. So at this time, we will get ready for questions and answers. So if you have anything that you would like to ask that has not already been put into the comment section, I'm giving you 2 minutes to do so now, and please tell me who exactly they are going towards. That way we can direct the correct panelists for the answer. All right, so let's get into the questions. First set of questions I have for Ms. Kendra Holmesley. So please come back to the camera. All right, so first question, how long does it take? I'm assuming,
Okay,
like,
I
how
thought
long?
not finished.
Yeah, how long does it take the program, I guess, to complete the
So
program?
at Bradford, we have different levels of care. So our primary program, our typical stay there is somewhere between 20 and 30 days. And then our extended care program that I mentioned, or our veterans program, like the Heroes Path, is 6 to 12 weeks typically. But of course, we have outpatient after, or we do have 2 long-term facilities called the Reprieves that are in Opelika and Auburn, and they are 6 months to a year. And one thing I didn't address is there are other programs besides Bradford and what we offer. Obviously, there are state-funded facilities. All of them are going to vary on length of stay based on level of care. So to access a state-funded facility, you would need what's called an ASAM, which is a state assessment. And you can get those done at like Recovery Resource Center in Birmingham. If you don't live in Birmingham, Recovery Resource Center will still do the consult. They can just do it via phone. And there's other agencies. Ross is a great resource for getting those as well. And then there is the Alabama Alliance for Recovery Residences. There's a website for that at aarronline.org, and you can find a list of our certified recovery residences for the state of Alabama. And those are all vary in length, typically about 6 months to a year. Like Ashley mentioned, her program is a recovery residence and hers is a year-long program. So that's a real typical stay in sober living. And it takes a different length of time for everyone. So my recovery journey, I went to a recovery house, and it was a 6-month program, and I ended up staying for 16 months. So they allowed me to stay longer until I handled the things that I needed to handle and was ready to walk out those doors to live life, on life's terms completely. But it really is individual, and that's one reason it's important to get those evaluations done or talk to somebody about what do you think's, the best, what do I need to do? And so we recommend a lot too. People come in for treatment for 21 days or 28 days at Bradford. We often recommend that they go on to sober living and attend outpatient as well. So, everyone's journey is different, and you just got to find what works for you. And I should note too, some people get sober without ever going to treatment. Maybe they just go to 12-step groups like AA or NA. Or there are Celebrate Recovery programs if you are wanting something in the faith-based community. And oh, and there's ACRM too, which is the faith-based version of the Alabama Alliance for Recovery Residents that certifies the faith-based programs. But y'all have my email. If you want any more of that information, I'm happy to send it to you anytime.
Thank you so much. All right, so we have our next question for our U.S. Attorney, Prim Escalona. Would you please come to the video chat, please? All right, so what are the most common ways fentanyl are getting into our communities?
I think if you're talking truly about fentanyl, it is being brought in by traffickers. What we see the most of, I will say, because at the federal level, our ability to prosecute is pretty narrow. And so we try to focus our resources on traffickers who are bringing in the largest amounts of drugs. And so a lot of that is coming in from Mexico and other countries. And that's probably, for what we see, the largest pipeline. But again, that may be a little bit different if you were to talk to a state prosecutor.
Okay, thank you so much. Thank you. Let's see who we have here. All right, Mr. Eugene Jacobs.
Yes, ma'am.
Okay, so your question is, in what ways is the FBSS program working to engage with local faith-based sober living facilities?
What we do when we go into different areas is we network with the treatment centers and prevention centers, providers in their areas, and we bring them to our conferences where they set up vendor tables. We give them a space where they introduce themselves, because we're not trying to overstep anyone's boundaries in terms of prevention, and we're definitely not a treatment center. We're trying to connect faith leaders with the people who are already in their areas.
Okay, thank you so much. We have one for Miss Ashley West. And they want to know, what ways did you positively cope with while in rehab?
So for me, we're talking about being part of the opioid crisis. I got the way that my addiction started was because I had a kidney stone when I was younger. So when I actually started because I needed pain medicine, and that transpired for me for using that for every aspect of my life to cope with anything. And so what happened for me when I got into treatment is they got me connected with other women, and they were not only teaching about triggers and coping skills and what they did to get sober, but I started following each woman's experience. I would look to people with long-term sobriety, and I would figure out everything from how they were saving money to learn to become more financially secure, to what were they doing to reintegrate into their families' lives, how were they cleaning up the wreckage of their past. And I would literally find people who had something I wanted, and I would do what they did to get what they got. So the coping skills for me were finding women who were using positive aspects of their life and just doing what they did and being open-minded and taking suggestions, remaining teachable.
Great answer. I love that. And I'm gonna go ahead and say your other question. They want to know, how can community members contact you for speaking engagements?
I can put my email in the chat, and anytime anybody asks me to do something for recovery, I'm more than willing. I'm going to show up scared and nervous every single time, but I will definitely be there.
Okay, please do so. And again, I don't know about the nervous part. You do just fine.
Thank you.
Okay, and Shandy, well, you're right here. I'm just slide so you can come on in. What advice would you give to a young adult that's currently experiencing this form of neglect?
So if a young woman is experiencing this kind of neglect, young woman or young male, I would just suggest find someone that truly cares and truly will listen and knows their resources that will be able to help you. Because if you're going to go to somebody that's just going to coddle you, it's not going to help. I know that. I've been there, done it. You got to have somebody that's willing to take action for you, because you're going to continue to be in it if nobody's willing to do that for you. You need someone very informative as well, because if nobody knows how to help you or where the resources are, it's also going to be no help to you. So I would just say, really find someone that's going to be able, that you can tell your story to, or what's going on with you, that's really going to latch on and take action.
Thank you so much. Thank you so much. All right, I have a question for Miss Amanda. Okay, there she go. So your question is, if overprescribing led to many opioid use disorders, what is the medical community doing to remedy the past negative results?
So that's a great question. That's one of the biggest, essentially calls to action for going forward. So we now have the CDC has their recommended opioid prescribing practices. There's lots of restrictions about prescribing. Even pharmacies have implemented their own restrictions. So, for example, I know like at Walmart, when my mom had surgery, you had to take special special tasks had to happen before someone else could go pick up her medicine. And even then, if she had had certain medicines prescribed in a certain amount of time, like they have their own rules specific to each pharmacy, in other words. So it's not just the providers that have guidelines now. Pharmacies are doing their own thing. They've also implemented like the buyback program. So recommendations for prescribing are much shorter amounts of opiates for shorter amounts of time. And so if you happen to have leftovers, though, they'll do the, not really buyback, but take back programs where you can take them your empty bottles. A lot of teenagers you'll find are getting started on opiates simply because it's in the house and it's available to them in their medicine cabinet. So if you take that away, that's one less risk factor you have, and pharmacies will destroy it for you. You just have to take them back in. So it's like a multi approach from different areas. But as far as physician prescribing, the CDC does have those recommendations, and pharmacists are really particular, and they make sure they're following up with making sure those are enforced.
Okay, thank you so much.
Sure.
Our next question is for U.S. Attorney Prim Escalona. They want to know, how can the general public access additional information on naloxone, or are there any seminars?
The best way to do it is probably to contact your local county public health office. I know that Jefferson County Public Health provides a lot of naloxone and also knows resources for it. So that would, and the training for it. So good place. That's always a good place to start in your county. And then also usually a sheriff's office is another good spot to at least kind of reach out as your first contact.
Okay, thank you so much. And Amanda, I believe a question just popped up for you. How long after detox do opioid cravings start to slow down without it just went away?
I think I accidentally answered it by text also, but I'll be glad to cover it a little bit. So essentially, a lot of it depends on what opiate you're using, how long it stays in the body, and how long you've been using it. If someone's not on MAT, if they don't have something to help combat the longer term withdrawal, they could experience some form of withdrawal symptom for 6 to 12 months. It could be things like obsessive thoughts, or kind of just ongoing anxiety, headaches, stomach cramps. They could have some of those here and there for months to come. Patients who maybe were prescribed methadone and just didn't do well with it, or were on it for a long time, or ended up abusing it, or ended up somehow getting it off the street instead of going to the clinic as it should be prescribed. that methadone will sit in the fat cells for months and months. It's very long acting. So those that are using methadone off the street or illicitly could experience withdrawal symptoms for even longer because a lot of them are also using it in conjunction with other substances. So that medication in particular is stored in the fat cells, and so it could be months before your body is completely completely eliminated it. So it really just depends on which opiate it is, how long they used, and what type of, if they're not doing MAT, how engaged and how invested they are in their own recovery program. And we never say that there's only one way to get sober. We would never say somebody has to do, 12 steps to get sober. We are a 12-step program, but obviously there's more than one way to achieve recovery. So if that's SMART recovery, Celebrate recovery, faith-based recovery, whatever it is, how engaged they are and how much they're working their program is also going to be a factor if they're not going to do MAT. But yeah, those withdrawal symptoms could be months later.
Okay, Amanda, while I already have you right here on screen, you have some more questions that I'm gonna go ahead and have
Okay.
you. You're on the
Sure.
roll. You're on the
All right, let's go.
Is there any age limit for MAT programs at Bradford? And if so, what are the limits and requirements?
That's a great question. I can tell you that we treat 19 and up. So 19 years old and older is where we are. We do have, and Sherry, if you know more about this, then feel free to speak up. But we do have one program in North Carolina that treats teens or adolescents, and that's usually 13 to 18. As far as MAT, I don't believe Suboxone is approved for under 16. And I don't know, I'm sure methadone's probably not for even, I bet it's not unless you're an adult. I don't specifically know, but that would be my guess, is that you have to be an adult to use it. But yeah, we in Alabama and Mississippi, I think, and Tennessee, we are 19 and up.
Thank you so much, so much.
Sure.
Okay, I give you a little break for a second. So this next question is for Ashley. What's the best way to approach someone who's in active addiction?
So it really just depends on if they're wanting help or not. I was actually thinking when y'all were talking about how, some people come in and they're just addicted to prescription medicine, or some people come in and they're already buying drugs off the street. And I've actually had the experience of going to the dope house, getting a girl out of the dope house as soon as she was Narcan, bringing her straight here, getting her to detox. So for me, it's just about meeting them where they're at. And, like she was just sharing, for me, a 12-step program is what works, but I do believe there are many pathways to recovery. So it's about finding one, what's best for them. For Silver Lining, just for us, we're not worried if you don't have any money, and we're not worried about where you come from or if you don't have anything. We're going to meet you where you're at, pull you up right where you are, and give you everything we can to help you get to recovery. But if someone wants to go another way, but that's what we do. I'm here to help people recover no matter what pathway that they choose. So it's about meeting them where they're at and figuring out what resources work best for them. When I worked at the detox, we would look at what insurance they had, if they were wanting MAT, if they're wanting 12-step, or if they do relate more to faith-based. So I think it's about staying connected. One of the things I'm blessed with here in Calhoun County is having a strong recovery network from people from all avenues. So I'll actually reach out to Kendra or Marby or whoever, and we'll just figure out what works best for them.
Thank you so much, Ashley. All right, and I have a question for Chandy. What words, excuse me, what words of encouragement will you share to the youth?
So I think my words of encouragement would be just to keep going. A lot of times when I share my story within our dream program at the schools, young ladies always ask me, like, how did you know that you didn't, how did you believe that you couldn't do it? Like, what made you not give up? What made you not fall into addiction like your siblings or your mother or like anything with all that around you? Because wouldn't it just be easier to give up and to just give in? My encouragement to them is just find people to surround yourself with, positive people. It is very hard to keep that positive mindset when you're in this kind of situation. But I'll be honest with you, I don't know how I pushed myself through it. But a lot of the people that I surrounded myself with, like at church, their positive encouragement did help me. It did lead me to know that I did want to have a brighter future. So my encouragement is to not give up, keep pushing. And although it seems like you're not going to have this great outcome like I did, you're going to. You're going to have a good outcome. You got to keep pushing through, and you will make it through.
Thank you so much, Chandy. Thank you so much. Okay. We have made it to the end, you guys. So this concludes today's session. Special thanks to all the panelists for taking the time to provide valuable information to us. At this time, if you have any announcements or contact information that you would like to provide, drop it in the chat box. And as they are doing that, I'm going to stop right there because I have a secret. We did not promote the fact that, well, we did promote that we were doing a $250 gift card, but of course I'm going to do it at the end because it's all about the ones who stay to the very, very end, okay? So as we was doing questions and answers, my coworkers were pulling a name. So the lucky winner of the $250 gift card is Mr. Robert Teague. So if you could, please put in the chat box your information, your phone number, that is, so we'll be able to call you and set up a time where we're able to at least, hopefully if you're close by, we can give it to you. If not, then we'll have to mail it off. But congratulations, Mr. Robert Teague. And you got a lot of congrats. All right, so also at this time, if any of the RT committee has announcements, please drop it in the chat box as well. Please remember to be on the lookout for the post-session email with materials from today's presentation and survey link to complete the evaluation for your CE certificate. The survey will need to be completed within the next 30 days in order to receive CE credit and a certificate. Excuse me, y'all. All right, so announcements on our end while people are dropping theirs off in the chat box. I can't get it to come up. Okay, but we have scholarships out at this time. ASAP, we are offering $500 scholarship to students who will be attending an institution of higher learning upon successfully graduating from high school in the following counties. There will be Calhoun, Clay, Cleveland, Coosa, and Talladega counties. Please visit our website at asaprev.com for scholarship applications, or you can email agencyabuse@gmail.com. We also have Take Back coming up, which is a National Prescription Drug Take Back Day where we take in any unused or expiring medications from 4 of our locations with the DEA checkpoints. So we have Jacksonville Walgreens, Anderson Walgreens, Oxford CVS, and Wright's Pharmacy in Heflin. Once you dispose of your unused or expired medication at one of our locations, you will enter into our raffle for a chance to win a 50-inch smart TV. Again, a 50-inch smart TV. As we mentioned, surveys will be emailed to you all to help ASAP seek new ways to make the next opioid roundtable better. And also, Eugene, do you want to make that last announcement about the FBSS training coming up? Reverend Eugene? Eugene? Okay. Well, the dates are April 11th through the 13th, 12th, I'm sorry, April 11th through the 12th. I'm in Dothan at the Troy University campus. I'm sorry, I don't have the note in front of me. But yes, I'll be able to have Bradford to send out all the information for any upcoming things we have within the next few months. And I'm trying to get the chat box up, Robert. There it goes. Okay. Give me 1 second, you guys, and apologize. Robert, I'm looking for your number. If you could just email agencyabuse@gmail.com. I'm putting it in the chat box now. And just email your information.
I got it, Aisha. I'll send it to you.
Okay, thanks. And again, I'm also dropping our website for anyone who has any students in those areas who would like to apply for our scholarship that is due April the 5th. Okay, thank you all for attending, and I hope you have a great rest of the evening.